Service Implementation Simulator aims to create a virtual model of the service based on given characteristics. This means each of the pilot regions now have the possibility to build a simulation of the services based on their own local situation. The assistant tool may generate a suitable way of using ICT, and not just in a specific region, but for each individual patient as well.
So then I hand over to Ingo to introduce you the Service Implementation Simulator.
Yeah, like I said, I mean, this is something that we originally did for SmartCare because we needed a training tool for the Assist tool. And basically, I mean, you've had a look probably at the Assist tool earlier on for CareWell, and
yes.
Normally the Assist tool does not contain any data, because this is where you put in your data for your service in your project. But the Service Implementation Simulator version actually does contain data. So basically what we have done, we've created what we've called an example case scenario. So that's a hypothetical case for integrated care, and put that into the tool. And we took data from previous projects, and we took some ideas from SmartCare, put all of that into the tool, so that in this version of the Assist tool you have actual stakeholders doing certain things, and you do have data for those stakeholders. So, and I'm going to explain a bit more what the service is supposed to be, what the idea behind it is. What we've assumed for the model case is that we're looking at a service addressed to older people suffering from COPD, and also a service addressed to the informal carer, so family members, friends, looking after those COPD patients. And basically, there are three elements to this service. On the one hand, it's an early supported discharge program. So a COPD patient goes into the hospital following an exacerbation, and then is discharged earlier than he or she normally would be, because they would then receive telehealth at home. So that's something that we did in another project. The reasoning here is you can either keep the patients in the hospital to monitor them, or you can send them home and remotely monitor them. And obviously, if that works out, you are saving bed days in the hospital. So this early supported discharge program with telehealth is one element of the service. The other is a video-based physiotherapy program. Probably know that physical fitness is an important factor for COPD patients. They usually have severe problems with that, but if they are doing physiotherapy training, they can actually cope better with some of the symptoms of the disease. So here we have video-based physiotherapy, and that basically means that, I think we assumed it would be once a week, a patient connects via the internet with a webcam and a Skype conference call to the therapy provider, and receives physiotherapy via video conferencing. So that's also something we had in another project. There was actually a phase where the people would receive real-life physiotherapy for a couple of weeks, so to get to know the exercises they would have to do, and then they would switch to the video program. And that's here the second element of this hypothetical service. And the third element refers to the informal carers, and these are supported by a voluntary organization. So there is something like the Red Cross or the Alzheimer's Association who's looking after those informal carers and providing counseling services, telehealth meetings, giving them information, and other things. So these are the three main elements of the service. And we're going to go into the details of what different stakeholders do within the service in a couple of minutes. What's maybe important to say that the basis for the service are common care pathways, basically the ones we developed in SmartCare and are now also using in Beyond Silo. And all the stakeholders involved in this service have agreed on collaboration. So they have drawn up a kind of collaboration contract that is the basis for all that they are doing. They work according to these common care pathways. And mainly this means that they do joint care planning, and they are also operating a shared client or patient record, so an electronic health record where all the data from all the patients goes in, and then can be viewed by all the different providers involved in the service. So that's in a nutshell this model case that we have put into the tool. You can again read all about this also in the guidance document. They describe it in a bit more detail. There is a number of stakeholders involved in the service. We have the COPD patients that are, if you so will, the primary target group. And I think we envisage those to be exactly patients 60 years or older with COPDs and possible comorbidities. And most of them actually will be smokers. So these are the COPD patients. Then we have the informal carers, which are family members or friends looking after that person. We have a telehealth call center that is responsible for the telehealth monitoring part of the early supported discharge program. And that is run as a private business entity, if you so will. So it's not a state-based telehealth provider, but it's a private company. They look after the provision of the telehealth, they look after installation, and they also run a call center where they do what we have called technical triaging. So they monitor the telehealth readings and pass on any alerts to social care providers, the GP, or the hospital, depending on what the situation demands. So you probably have to imagine that there are some agreements or threshold values set, and then they have rules that tell them, okay, in this case, you have to go and call the social care provider. In the other case, you have to go to the hospital. Currently, the call center receives a service fee that is paid by the COPD patient that covers about 50% of the cost of operation. And this is going to become important later on. And then we have the GPs, the primary care organizations. They are also private organizations in this case, financed from a public budget. So imagine something like the situation, for example, that we would have here in Germany. GPs are private businesses, but they receive their funding from the mandatory health insurance system. And they would usually provide day-to-day care to the COPD patient. There has been a shift with the introduction of the early supported discharge program, because now the primary follow-up is no longer being done by the GP, but it is being done by the social care provider. So you can imagine this as a kind of cost-saving measure. The GP remains only responsible for certain types of follow-ups that require a doctor, basically, but cannot be done alone by a social carer or by a nurse. And this means that the number of consultations at the GP practice has actually gone down. And this means that immediately the GP has lost income. Because this is how it works in Germany. I don't know about Bulgaria, actually. But this is how it works in Germany. A GP is financed on a DRG basis, so per treatment, per case. And as soon as he loses treatment, he also loses the reimbursement. What's important, we also have the hospital. Those are now public institutions. They are financed directly from budgets that they receive from the state. So they have an annual or triennial budget they receive from the state. They provide the care to the COPD patient, and due to the early supported discharge program, they liberate beds in the hospital, and they're also avoiding readmissions because the patients are now being closer monitored after they have been discharged. And this means that a considerable amount of staff time is being saved. And yeah, they have, like probably all hospitals, they have a waiting list of patients, and these waiting lists then can be shortened because the beds are freed earlier. Then we have the physiotherapy provider, who is also a public provider, part of a larger institution, providing different types of health and care services to not only to older people, but also to children, people with disability, and so on. And again, the whole institution is financed from a state budget. And for the physiotherapy, with the video program, what they can do now is they can actually look after more clients with the same amount of physiotherapy staff, because mainly they are saving travel time and time to set up meetings. People can just connect remotely to those sessions, and they can look after more clients. And those clients pay a monthly fee only for the video service. This is, however, not intended to cover all the operational costs, but just as an added benefit. And then we have the social care providers that are, again, private business entities, again, similar to Germany, financed from a state budget on a case basis. And they are now, with the early supported discharge program, looking after the COPD patients, doing the immediate follow-up based on the calls received in the telehealth call center. And that means they actually make more money because they're looking after more patients, they're looking after more cases, taking this over from the GP, or a large part of it from the GP. And finally, we have the Carer Support Organization. As I said, it's a voluntary organization funded through membership fees, fundraisers, and state aid. And most of what they are providing is actually delivered by unpaid volunteers. So staff costs are not such a big issue for them. There's only a small core team of staff that's actually employed by the organization and deal mostly with managerial and administrative issues. For them, what this service meant is a bit more complex than probably for the other organizations. With the introduction of the service, they received a widespread implementation of IT systems, and mostly computers and mobile devices that they did not have before. So you have to imagine that before they were running their office mostly on paper, and now they're running it on computers and tablets and mobile phones. And this has led to considerable efficiency gains in the organization's administration. And that, again, that's an actual case that we had in the independent project, where we really saw huge benefits just from them using computers instead of paper, apart from all the rest. So that's, in a nutshell, the service scenario that is built into the tool that you have in front of you. I think what's important, rather than memorizing everything I have said, it's also in the document, that there is a lot of stakeholders involved, and it is important to bear in mind who would actually benefit from the service and who is currently not benefiting or having increased costs because of the service. And that's something we're going to look into in more detail later on. But now we will start going into the tool. And the way we have set this up is that there is a number of lessons. If you had a look at the document, you can find that there are actually 5 lessons. We will look at the first 3, 0, 1, and 2 today. And yeah, like I said, most lessons are about that currently in this model there is a number of problems with the service, and these problems would ideally have to be fixed. And that would require also from your end, once we go into those lessons, that you start thinking about, okay, where might those problems be? Do I have an idea how they can be addressed? And I don't know exactly for your case, but usually some of those elements might be something that you have also already encountered.